Good afternoon, and thank you so much for having me. I just put a few slides here and some pictures of the lumbosacral plexus looking at the nerve of origin compared to the femoral nerve. For instance, this tumor was arising from L5 on the left-hand side. And what you can see on the right side of that slide is the tractography looking at the normal fascicular structures compared to the tumor itself. And that is very useful when you are looking into surgery like this to remove these tumors. And like Rob has introduced very well, like the lower pictures are about the brachial plexus and the tumor, that origin, again, from C7, and you can see very clearly like the normal track and where this tumor is arising from. And it's really important to know that in order to have a successful surgery. And the green pictures there is just showing the ADC values. That gives you a good idea about if it is more on the malignant side, looking at the diffusion of these tumors. So first of all, I'd like to thank Mark and Zarina to put like a great course together again. And also my team of people that without them, these pictures will not exist. And I would say that to answer the questions that Mark asked me about how to get that right is about the discussion you have with them, determine very clearly what you need and have those people that you can talk to and make sure that they give you what you need when it comes to dealing with peripheral nerve surgery. So the eye resolution imaging is really important in a nerve practice. It's really help to plan your surgery. So the MRN will enables you to assess the anatomical extent from the different pathology, distinguish between benign and malignant, plan your operative management, and determine also some surveillance strategy. The MRN tractography and DTI is not new. So if you look at the literature, Aaron Filler, like back in 2009, has written all about the history and the origin of the DTI and the neurography and its clinical impact. So what we did do, though, is really making sure that we're using it and that we are like getting experience with it and getting better images as we move along. The FA will estimate the nerve fiber tract integrity. The ADC value, again, will measure the mean diffusion, and the tractography will really estimate the neural tract, as you can see on the slides. And this is just an example of trauma cases that you can see. Here, a neuropraxia, some partial tear with severe exnominasis, and the DTI from a carpal tunnel that you may have sit on it like a while ago, but now that you're seeing clearly that there's innervation and neuroma and discontinuity of those fibers. So no longer you need to sit on this, but you need to reoperate and repair that. And then another example of dorsal scapular nerve that you can evaluate with a tractography. And you can see very clearly the denervation of the rhomboid major. So really like those images can help you making diagnosis and treat the patient. And here you're seeing the difference between a schwannoma and the normal fascicular structure around that nerve and tumor. And the same thing, the same type of images, the lumbosacral plexus, where you're saying that it's very different with MP and ST when the tracks are completely different than if you're looking at a schwannoma. So the neurography will really help you with when a tumor is benign with target sign, fascicular sign, tail sign, and ADC values, where it will be very different with an MP and ST. So the clinical correlation and the MRI features will really be helpful. And here's, again, like the ADC values that will help you with the metastatic disease or the lymphoma. So here is the example of the split fat sign, the target sign on the left-hand side, where you can appreciate the correlation between the pathology with Anthony A and B features. You can see also the fascicular signs that in T2 will really look into a fascicular structure of the nerve, and then the tail sign with the relationship between the mass and this fascicular structures as well. The MRI neurography appearance compared to the MRI will really help you to determine more clearly the diagnosis of benign tumor and will really like determine and delineate this lumbosacral plexus and the origin of that tumor. So you can see that better images are really clearly on the lower slides. And then here, it's another example of a patient where you can see that the sensitivity, the specificity of the DTI is really correlating with this peripheral nerve tumor. So with what you can find in the operating room. Here is an example again of a brachial plexus where you have those DTI images, the ADC values, and the correlation, what you can get with an ultrasound, and the relationship with the intraoperative pictures. So basically, I think that I convinced you that like the mean ADC and the absence of sign, are really something that you want to look into in PNST, and that for the benign tumor, you can have those signs that I talked about. Here is a big tumor that you would think that it's really like there's some red flag for a malignancy. But if you look at all those signs, this was a schwannoma. Some tumor will be more difficult and will be like more plexiform and infiltrative, and the MRI will really help you to determine where is the nerve into that and how much infiltration there is. And then when you have like a patient who had the brachial plexus infiltrative lesion like that with progressive neurological deficit, who had a previous breast surgery and radiation therapy, a biopsy determined that it was a sarcoma arising from it. You have the ultrasound, the SUV from the PET scan, you correlate that with those images, the MRI neurogram, and you can see that this is like infiltrative in nature, and this was like basically a Triton tumor. So following that patient will be very important, and the DTI as well as the ADC values will really help you determine what type of resection you've been able to do. Here is an example of a lymphoma that really distracts all those fibers. And once again, those images are really helpful to determine all of this type of problems. Same thing with the perineural infiltration from secondary cancer, such as breast and lung. So in conclusion, I think the MRI neurography is really helpful. The most important thing is to assess the anatomical extent, distinguish between benign and malignant, plan the operative management and surveillance strategy with the ADC value. But the most important thing is to talk with the neuroradiologist and make sure that you get what you need and that you keep improving from that. Thank you.